All right, welcome to The Explainer. Today, we're doing something a little different. We are putting you right in the hot seat to simulate one of the biggest hurdles in a surgeon's career, the consultant viva. This is an oral exam where your knowledge gets tested under some serious pressure. So to make this as real as possible, I am actually going to play both parts. I'll be the toughest nails examiner, the one asking all the hard questions. And then I'll switch hats and become the candidate, showing you how to methodically break down your answers, stay calm, and think logically. The whole point here is to walk you through a classic, complex surgical case, from the moment the patient walks in the door all the way to their long-term care.
Good morning. Please have a seat. We're going to discuss a clinical case. Now, I want you to manage this patient as if you were a day one consultant surgeon. Ready to begin?
Let's begin. A 19-year-old male presents with a 6-month history of intermittent rectal bleeding and diarrhea. His father died of colorectal cancer at age 38. How would you proceed?
Thank you. Okay, so right off the bat, you have a 19-year-old with that incredibly strong family history. That is immediately concerning. My approach is going to be systematic, starting with the fundamentals, a really thorough history and a focused physical exam. After that, I'll move on to some baseline investigations to start building the clinical picture before I order the definitive test that I'll need to lock in a diagnosis and formulate a management plan.
Very well. Let's focus on the history. Tell me, what specific information are you trying to elicit here?
Well, first, I need to really characterize his symptoms. The nature of the bleeding, the diarrhea, is there any pain or mucus? Then, I am going to dive deep into that family history. The father's cancer is a massive red flag, so I'm specifically asking about polyps, the exact type of cancer, and the age of onset for any affected relatives. And because agenetic syndrome is high on my differential, I have to ask about other seemingly unrelated signs, things like unusual skin lesions, dental problems, or even bony growths, which could be clues for FAP. And of course, I need a clear picture of his overall health, because this young man could be facing major surgery.
His general examination is unremarkable. However, on digital rectal examination, you feel what can only be described as a carpet of small, soft polyps starting right from the anal verge. What is your definitive investigation?
Okay, with that physical finding, a polyposis syndrome is now at the very top of my list. So the next absolutely non-negotiable step is a full colonoscopy. I have to visualize the entire colon and, critically, get biopsies to confirm the histology, to know exactly what we're dealing with. The colonoscopy is performed. It reveals a wall-to-wall carpeting of the colon and rectum with well over 1,000 polyps. Biopsies come back, confirming they are tubular adenomas. What is the diagnosis? This clinical picture is classic for familial adenomatous polyposis, or FAP. It's an autosomal dominant condition which is caused by a germline mutation in the APC tumor suppressor gene located on chromosome 5. And that finding of more than 100 adenomatous polyps is diagnostic. And look, this is the absolute key here. For a patient with this diagnosis, the risk of developing colorectal cancer isn't just a possibility, it's a virtual certainty. It approaches 100% by age 40 if we do nothing. So this changes everything. We are no longer just managing his symptoms, we're in a race against time to prevent a guaranteed cancer. Good. You've established the colonic risk. But FAP is a systemic disease. What are the key extraintestinal manifestations you must be screening for and managing in this patient's lifetime? You're absolutely right. We have to think way beyond the colon. I'd be looking for osteomas, those benign bony growths, and specific retinal lesions called CHRPE, which can be important diagnostic clues. But the really life-threatening ones are the desmoid tumors, which can be incredibly invasive locally, and, crucially, duodenal adenomas. These polyps in the upper small bowel have a really high malignant potential and are actually the second leading cause of death in FAP patients, right after we've dealt with the colon. Exactly. So let's be crystal clear. This surgery isn't elective, it's prophylactic. It's an operation to prevent a guaranteed malignancy. Now, given his young age and this diagnosis, what are his definitive surgical options? Okay, so there are really 3 main routes we can take here surgically. We could do a total abdominal colectomy and connect the small bowel to the rectum. But that leaves the rectum behind, a rectum that has a very high risk of developing cancer down the line. Option 2 is to remove everything, colon and rectum, and give him a permanent ileostomy bag. That's the safest from a cancer perspective, but it's a huge change to his quality of life. So, for a young, otherwise healthy patient like this, The gold standard is the restorative proctocolectomy with an ileal pouch anal anastomosis, or an IPAA. It's a complex operation, for sure, but it removes all the tissue at risk of cancer while creating an internal pouch from the small bowel that allows him to maintain continence. It really offers the best balance between cancer prevention and his future quality of life.
Now, within that IPAA operation, there's a really key technical decision to make. If the very lowest part of the rectum is clear of polyps, you can use a double staple technique. It's quick and it works well. However, in this patient who has a carpet of polyps all the way down to the anal verge, a hand-sewn anastomosis with what's called a transanal mucosectomy is required. You have to do this to be absolutely sure that every last cell of that at-risk mucosa is gone.
An excellent and important point. All right, let's put you in the operating room. You're creating this J-pouch, but you find you just can't get it to reach the anus without a lot of tension on its blood supply, the mesentery. What specific maneuvers can you perform to gain more length? Tension is the absolute enemy of a safe anastomosis. It compromises blood supply, and that leads to leaks. So my first move is to fully mobilize the small bowel mesentery, taking it all the way back to its root at the superior mesenteric artery. If that's still not enough, I can go high and divide the ileocolic vessels. That often frees up a surprising amount of length. And as a final resort, I can make very careful, deliberate releasing incisions into the peritoneum that covers the mesentery. This lets the tissue stretch and fan out, and hopefully that gives me the last couple of centimeters I need for a completely tension-free connection. Very good. The surgery is completed successfully. But your job as his consultant is far from over. His surveillance is for life. We've talked about colorectal cancer and duodenal cancer. What is the third most common cause of death for a patient with FAP?
That would be desmoid tumors. Now, these aren't technically cancer because they don't spread to distant organs, but they are incredibly destructive where they grow. They are often triggered by surgery itself and can grow like concrete inside the abdomen, encasing and strangling the bowel and its blood supply. They are a true nightmare to manage. And yes, they can absolutely be fatal. So his post-op care plan is lifelong and really has 3 key pillars. First, we need to scope his new pouch every year to check for any issues. Second, we have to start regular endoscopies of his stomach and duodenum to monitor for those high-risk adenomas. And third, and this is crucial, we have to maintain a very high index of suspicion for desmoid tumors. That means any new abdominal pain or a palpable mass needs to be investigated immediately and aggressively.
Thank you. That will be all. Whew. Okay, let's take a breath and step out of the exam room. As you can see, the candidate passed, and they passed because they showed a structured, deep understanding of the entire disease process. Now, let's boil this all down to the absolute must-know, high-yield points from that scenario.
So let's distill this. First, the genetics are everything. FAP equals a 100% cancer risk, which means the surgery is prophylactic, not elective. Second, this is a whole-body disease, not just a colon problem. You have to be actively looking for those duodenal polyps and desmoid tumors. Third, the IPANOM might be the gold standard for quality of life, but it is a technically challenging operation, and you absolutely must know those tension-reducing maneuvers to get you out of trouble in the OR. And finally, you have to remember that the surgery is just the beginning of a lifelong partnership with this patient, one that requires a whole team and relentless surveillance. And that really brings us to our final thought here. You see, the surgery fixes the most immediate threat, but it doesn't cure the genetic condition. It removes the primary target organ, but that patient's APC gene is still mutated in every single cell of their body. So the real long-term question becomes this: how does that fundamental genetic truth change the way you manage every other aspect of this patient's health, from their duodenum to their thyroid to their family planning, for the rest of their life? That is the true essence of managing a genetic surgical disease.